Aloha, welcome to Healthcare in Hawaii. I'm Josh Green, Senator and physician, and your host today here with ThinkTech. We've had an excellent discussion about healthcare in our state over the last several weeks. We started with Beth Giesting, the Healthcare Transformation Czar for the Governor, who talked about healthcare transformation in its global approach in our state. Today we're going to get into some of the details and specifics about the projects that Beth alluded to. We followed that with a discussion with Hilton Rathel, Senior Vice President, HMSA, talking about how insurance affects our people. And of course that's a big issue today with the Health Insurance Exchange at first meeting some troubles and then going live this afternoon. We followed him with Dean Hedges from our medical school, and then George Green at the Healthcare Association. And then last week we had an excellent discussion with Dr. Linda Rosen talking about our trauma system here in the state of Hawaii. But today I want to dig into the details of really the future of healthcare, and that's information, health information. Today we have an excellent guest, Christine Sakuda, who is the Executive Director of the Hawaii Health Information Exchange. This is central to Obamacare, or the Affordable Care Act, as other people who aren't quite as angry refer to it. And Christine is going to give us kind of the details about bringing information, health information, into the modern age. So first I want Christine to join us and tell us about herself.
Thank you.
Hi.
Thank you, Senator Green, and thank you for having me today.
You bet.
I've been the Executive Director of the Hawaii Health Information Exchange since 2009, but I've been in the health information technology field since 1997. Back in the day when telemedicine just started, and
Wow.
we tried to connect providers from across the islands together and share clinical information with each other.
So your perspective is really from the beginning, because this is a field that's been just exploding lately, wouldn't you say?
Yes, it has been. It's been interesting to see how the system has matured from telemedicine and big computer equipment to things you can do on your iPhone or your iPad. It's just amazing how technology has evolved.
I'm dying to hear you give us some vignettes as we go through this hour about some of the novel ways people are using technology for healthcare. But let's, I think, start at the beginning. Where does the Hawaii Health Information Exchange fit into the whole, I guess I'd say, the global picture of healthcare reform?
Well, the Hawaii Health Information Exchange is a nonprofit.
Yes, Health Information Exchange.
That's okay. The Hawaii Health Information Exchange organization is a nonprofit, and we have a 20-member board made up of a broad cross-section of the stakeholder community. So we definitely have healthcare providers like the largest hospitals, Queens, Hawaii Pacific Health, HMSA, Kaiser, largest health plans. We also have some of the smaller ones that provide that critical safety net infrastructure in the state of Hawaii, like Aloha Care, Kilihipalama Health Center, and we can't forget the business community and the Chamber of Commerce and the consumers, for example, AARP.
So these are like leaders from the community in healthcare, but people who have been, I guess you would say, intimately involved with the future of healthcare.
Right. Healthcare advancement and improvement means a lot to all of them, and it's our goal as a broad stakeholder community to really develop that strategy of how information can be shared across the community. How do we all agree on the principles of doing that and moving forward with that? I've
heard people say he who owns the information is going to be running the show. Is that why they're all at the table with you?
Well, that's a good question. I think they're all there for improvement of patient care. I think at the end of the day, what's important to either the health plan or the hospital or the independent physician is improving care for the patients of Hawaii. Whoever owns the data, I think, is on the minds of a lot of stakeholders, but that's really not the focus of the Hawaii Health Information Exchange. It's our goal to ensure that clinical information gets passed between provider and hospital, lab and hospital, lab and provider, radiology specialists and provider in a safe and effective way.
So tell us why this is so important. I mean, we've heard the federal government, President Obama, talk about this a lot, and we hear words like electronic health records, EHRs, electronic medical records, health information exchanges. Why is this so important for us to, in Hawaii, connect everybody?
Well, information is knowledge. So if you have the right information at your fingertips, you're able to make knowledgeable decisions. And that's very difficult to do when most of the physicians in Hawaii, it's not the case today, but it wasn't the case too long ago, are on a paper record system.
Right.
It's very difficult for a primary care provider to send information efficiently to a specialist and back again, or for an ER doc like yourself who's trying to find out information about the patients that's presented in the ER.
Right.
When they come from the community, there's no information with them. And so if information is knowledge, we really need to help physicians implement tools that really help them to deliver care effectively and efficiently.
So is the goal, we've talked about quality. I'm so pleased that you're focused on quality of care, because I think, everyone has, I guess, their predisposition about these different programs and whether the Affordable Care Act is going to work for them or not, and the value of different programs. But since you're focused on quality, that's in everybody's interest, it would seem. It's the patients first and foremost. So what's the system meant to do for patients? How will this help? If I have a patient tomorrow morning that comes into the ER to see me, how would it help him or her?
Sure. Let's just say a patient shows up at your hospital that you're at, and for urgent care,
Right.
and you don't know any information about the patient. You don't know if they're allergic to anything. You don't know what kind of medication they're on, if they're on multiple medications, and you don't know their history that may impact the decisions that you make. So you would be able to query the Health Information Exchange, which is a secure web portal for information that is commonly shared among your patient's network of physicians,
Okay.
and able to get that critical information to help deliver care to them
Right.
while they're in your office or while they're in the ER. And that's very, very critical, because oftentimes it's when a patient transitions from one place to another is where the communication actually breaks down within the system.
Right.
So it's the goal of the Hawaii Health Information Exchange to make sure that those connections actually occur. So it's not all the patient's data flowing all throughout the system into a big warehouse for big data to do big analytics. Right now we're really starting out very purposefully to make sure that the physicians that really benefit from understanding what your situation is like and your health condition is like, to make sure that they get that information so they can deliver better care to you, or to point you in the right direction.
Right, and so that feeds into the question of the triple aim, right? Can we deliver better care in a more kind of effective, quality way, in a more timely capacity,
Right.
without making mistakes? That's where the triple aim has been focused, and
Right.
it all has to be mindful of cost, because everything is cost. And so the patient comes into the ER, and instead of being a blank slate, maybe they're elderly and they aren't aware of some of their conditions, or they're very complicated health problems they might have. They certainly might not know their latest data on
Absolutely.
how their diabetes is going, how their
Right.
kidney function has been.
Right.
This would enable me or some other physician colleague of mine to then quickly bring it up on the computer?
Yes, that's right. That's right. And the Health Information Exchange is really predicated upon all the community participants participating.
Got it.
So we really encourage all the hospitals to share their critical set of information, all the primary care providers to share whatever they can, so that those decisions can actually be made.
Okay, so I'm starting to, I have a pretty good feel for this, and I think we're going to dig into kind of each of the building blocks probably in our second segment. But as of now, tell us a little bit about where we stand. Are we in the first couple innings of a baseball game building the HHIE up, or are we coming down the home stretch already?
Well, I wish we were coming down the home stretch, because we can't seem to build the system fast enough.
Right.
And a lot of the stakeholders, I think, are really waiting for the day when everyone is connected and the information flows seamlessly and securely throughout the network.
Right.
So we're really in the beginning stages of that. We're in the active implementation stage now, where the Health Information Exchange is kind of like a grid that connects the different stakeholders together.
Right.
And we are in the process of connecting the first major stakeholders together, the major hospitals. We actually have interfaces being built with the Hawaii Pacific Health Hospitals, with Castle Medical Center and Hilo Medical Center.
Okay.
And we hope to onboard both major laboratories soon, as well as additional hospitals and health plans, so that they can make those critical connections and deliver care to the patients as best as possible. And it's a very it's a very long runway because we've been at this for a couple of years, as you know.
Sure.
And a lot of the first couple of years is setting up a good governance structure, bringing the stakeholders together, have them have a conversation on what the strategies are of the HHIE, making sure that they're comfortable and building trust within that stakeholder partnership for really the community benefit of the health information exchange. So that means that before any clinical information is shared, there has to be trust agreements in place, legal agreements on data sharing, governance structures that really adhere to national privacy and security laws like HIPAA, but there's some that extend beyond HIPAA, and those take some time to get through. And so we're very happy to say that over the first 6 months of this year, we spent developing the core set of HIE policies. They were approved by our board.
So this again is the 20 or so health leaders across the state where they had open discussion about, okay, this would be safe for sharing this patient's information. This would be a safe way to share lab data. This would be a safe way to share hospital experience data and x-rays or MRI scans.
And it's very evolutionary. So of course the stakeholders agreed to start off small by not sharing a lot of data, but agreeing to share the most common set of data that providers need throughout the system. So that tends to be transitions of care summary information that providers really need when a patient presents to them. And so we're very excited that there's broad support for that sharing of information. And so the data sharing agreements that were developed and the governing policies and procedures that were developed were again approved by the board of directors, and they're posted on our website.
Let me ask you this: where does the patient input come in? At what level can a patient say, I am okay with that information being shared, or, you know, I'd rather have that not be out there being shared with some other facility or another provider? How do we know that their interests are being protected?
That's a good question, and it's why we start off very small and very deliberate with the sets of information that providers actually need today. It's not, while the technology is innovative, the governing structure is actually very conservative because it is a complex set of laws and privacy and security laws, and we take patients' privacy very seriously. A patient can opt out of the system at any time. They can go to their provider and opt out, but when they do opt out, they opt out of the whole system. The technology system and the interfaces are not mature yet, or we don't feel very comfortable yet to be able to opt out of one system but not the other and let the data flow. And I think that's why we start off very deliberately with, again, your care summaries, discharge summaries from the ER, information that your primary care provider or your ER doc really needs to know about you.
Got it. Okay, well, I think that's a pretty good place for us to take a brief break. But when we come back, we're going to talk more about healthcare privacy and how this system is evolving with our information exchange.
Great, thank you.
So again, I'm Josh Green, your host at Healthcare in Hawaii, here with ThinkTech. Today's guest is Christine Sakuda, who's the executive director of the program. We're going to learn a lot about how this piece of healthcare reform is going to change the system.
I'm Bill Spencer, president of the Hawaii Venture Capital Association. We do monthly luncheon programs with ThinkTech about things that matter to Hawaii entrepreneurs, investors, and business service providers. So join us on the fourth Thursday of every month at the Plaza Club. For information about upcoming events or to join our mailing list, visit hvca.org. See you there.
Aloha, I'm Josh Green, your host at Healthcare in Hawaii, and today I have Christine Sakuda as my guest. We're talking about health information and how it's passed around in the state of Hawaii and really nationally. This is a national movement, a part of the Affordable Care Act, or Obamacare. It's very central to the healthcare transformation that we need in order to deliver better care, higher quality, safely, but hopefully more affordably. So we have Christine, who is the executive director, like I said, to inform us on how the system works.
Hello.
Hello again. So I was just telling Christine that we have people that complain about, is my information too private to be shared? How is it being shared today? And I wanted to get her comments about how this is going to improve the system, because I'll tell you a story. Sometimes over the years I've been in the ER and I have no one else. I'm on the neighbor island, I'm taking care of a patient, and I call up one of my colleagues on Oahu and I say, my patient has this challenge, this heart problem, say, and they say, well, send me a copy of the EKG. And I say to them, I'm sorry, my fax machine is out. I can't send it to you. And sometimes they'll say, well, just take a picture of it with your iPhone and text it to me. And I do sometimes. And it's not very secure, and the information is now just on, if I do it that way, I block out the name, of course, but that doesn't seem very safe or private, and that's not been a good system for us. This should solve that problem, shouldn't it? Tell us about your system.
Yes, well, right now the Health Information Exchange system is live, and what it's live with is what's called direct secured messaging. So it's like secured email, but it has a central authority that governs who gets to have an email account. And the only people that get to have email accounts are healthcare providers that are authorized by the HHIE. And so in the situation that you just explained, you would be able to send via secured email, kind of like a text, the image to your colleague. And so it doesn't require a lot of involvement in finding information and digging deep within your electronic health record, especially if you don't have time in the ER. But it's a very light and seamless way of doing that. And what is important to note about the direct secured messaging system is that physicians don't need to have an electronic health record. It's just like secured email. But it's compliant with national technology standards, so that over time a physician with a direct secured email account in Hawaii can connect to their colleague in Las Vegas, because we have a lot of residents in Hawaii that like to travel to Las Vegas, for example, on vacation. If they happen to show up in the ER there, they can connect to their state health information exchange and to their direct secured messaging system and connect back to us, to their provider here in Hawaii. So it's a very low technology but very broad applicability system that we have implemented today. And we have about 700 physicians that are connected onto our direct secured messaging system now. And we've been very successful, and it's been very well received, because it does help them communicate very quickly and very seamlessly with their specialists to manage referrals. If they need to send a secured message on a patient to another provider that may or may not have an electronic health record, it's a very low technology system to do that.
So they would say, so if I had an iPad, does that mean as long as I have the software and the technology can encrypt it or what have you, if I'm a nephrologist and there's a primary care provider out there seeing a patient, he or she could send me the lab data, and I could, even if I didn't have a fancy system, I could get it on that software? Is that how that would work?
Well, I wish I could say it was available on an iPad. Hopefully it'll be available on the iPad with the next release that's happening next spring. But right now, that same situation would be applied to if you were in your office. So right now, the technology works where it's actually implemented in a physician's office.
So does that mean though, as long as you have a computer and the internet, you are able to get the service?
Yes, absolutely.
Okay, and I could see how that would be very valuable, because though we will address, I'm sure, some of these other challenges that you've had, because I'm very interested in what people's concerns have been, whether they be hospitals or patients, but the idea that someone could call me or email me and say, this person has a tumor in the lung here, don't be alarmed, that's what they already have. This is not a new health problem.
Right.
Okay, and that's what we're now seeing with these 700 physicians?
Yes.
What-
Some of them use it actually very effectively to manage, especially specialists, to manage referrals that come in from primary care providers. So it's a very efficient way of managing that healthcare transition process from your primary care provider or your internist. When they send you to a specialist, they also have to send a whole bunch of paperwork and documentation, and you have to go with your own paperwork and documentation as a patient, and this really helps to make that process more efficient.
Right, that's been a big problem. I know that one of the sticking points in healthcare in general has been primary care providers, when they send someone to a specialist, not sending them enough information so that the patient can get a really good, high quality consultation. And then in turn, a lot of times, if we haven't sent enough information and questions forward, we duplicate tests. We don't necessarily get the questions that we wanted answered right then, answered succinctly and directly, and so it delays care for patients. It could be costly, I assume. I would assume this is going to cut down on waste, or that's one of the goals.
Absolutely, it's one of the goals. You're describing the situation perfectly, where if a provider has the information that they need, if the tests were already done previously, if a provider has an understanding of the patient when the patient shows up in your office, then, and if that helps prevent you from having to track down information about the patient, critical information, it really does drive down those overall systemic costs within the system.
Right, and delays too, right? I would assume that if you can get the information to the specialist or to whomever needs to have it in a day or an hour or whatever, it might decrease the amount of time they had to wait for that consultation.
Right, and I think that's particularly applicable in Hawaii, where there tends to be a lot of specialists on Oahu. And primary care providers on the neighbor islands refer patients to the specialists on Oahu. If the specialist does, oftentimes we've heard that specialists just don't really know why the patient is there. They're not specific enough. They know they might have an ear problem or a heart problem. They don't know what that is. The EKG does not come with them. And if they're flying over from a neighbor island, and if the specialist is not able to treat them, they'll have to fly back over again. And it really does waste a lot of time. It's a big inconvenience for the patient, especially if they have difficulty traveling, or if they come with a family member to help them. The whole goal of this system is to avoid situations like that to the best extent possible, so that when a patient does show up in your office, you have the information that you need to be able to take care of that patient and provide that quality of care to the patient.
So I can, for people out there watching, spell this out. I'm a primary care physician now. I work at, say, one of the health centers or even a private practice. I'm just a doc with my own little office. Maybe I have one partner. I see a patient, a 65-year-old man. He has serious health issue that I'm very worried about, a lung problem, say, and I need to send him to the pulmonologist. I do the referral. Everything in my system, as long as we're both participating, can then be shared, ideally, with that pulmonologist. Is that how it would start?
Yeah, well, not everything in your system, but I think your office can send to the specialist all of the critical sets of information electronically and securely to the specialist, to that pulmonologist, so that when your patient goes to the pulmonologist, they will be able to pull up that critical set of information on your patient and be able to treat them effectively.
And would that include their x-rays and their CT scan or their MRI of the lung in the case of this 65-year-old man with a lung problem?
Yes, if that primary care provider has that information and they're able to send it over, that would be great. And sometimes that primary care provider does not have that information, and that is where the second phase of the Hawaii Health Information Exchange comes into play, where instead of it being secured email, the pulmonologist is able to query the Health Information Exchange system and see general summary of the patient's conditions across the system. So the burden does not fall on the primary care provider to always gather all of that information, especially if those studies were resulted from other places.
So in that particular case, and I think we'll come to that as a kind of a seminal example of what the system can do, looking forward, for now, it's basic communication between
Yes.
providers.
Yes.
The next phase will include the radiology centers, the lab centers, those kind of core, I guess, institutions, giving information into the information exchange so that different portals can access it. Is that right?
Yes, over the next 12 months, we really are in a critical and exciting time of our implementation phase. We're not only connecting the hospitals together so that they can push out their discharge summaries into the community to those primary care providers and specialists that you described earlier, but also connecting the major labs, radiology, and medication management tool, so that when a provider does query the Health Information Exchange web portal, for example,
Right.
they're able to see the clinical summary, but also the radiology reports, the lab reports, and any medication that the patient is on. So we were told that those are the most critical sets of information
Right.
that would really help a provider deliver that quality of care to the patient.
Yeah, I can tell you from experience, that's the first thing we always ask for. Can I get a copy of this patient's labs? Can I take a look at his or her x-ray? Just because you want to know where you stand for a patient.
Absolutely.
And so you said that timetable is this next year, a 12-month period?
Yes, it does take time to bring on one hospital at a time and one laboratory at a time, and with each stakeholder, each hospital or lab or community health center, the agreements have to be signed, the data sharing agreements. The interfaces need to be developed, the technical interfaces tested, verified, so that the information that's flowing is flowing properly. And so we have an aggressive timeline to get the hospitals up within the next 3 years, and also the federally qualified community health centers that are on every island in Hawaii. So we're really excited about that.
Let me ask you one more question, or maybe two, before we go to break. So again, if I'm a freestanding doc out there in the community, do I have to sign up with the HHIE? I mean, who do I call to become a part of the system?
Yes, as an independent provider, you do need to sign up with the HHIE. And you can contact us at our website at hawaiihie.org. And I believe we can send that information out because we really want the provider to be connected to the healthcare community. And so it's very critical that the exchange system is really there to benefit, in particular, the providers within the community that oftentimes don't have that information from the hospitals, from the labs, from radiology, or the specialists. And those are becoming more and more the medical home of the patient. And that's where the role that the Health Information Exchange plays in the large healthcare transformation efforts, the large Affordable Care Act efforts really come into play.
Got it. So they sign up. Do they sign up also with their organizations like the independent physician organizations or the primary care association, or is it better that they sign up just by contacting you guys at the HHIE?
It's best if they sign up contacting the HHIE, because the contractual agreements
Yes.
is between the HHIE and the physician.
Got it.
And so those are supported by the HIPAA policies, the privacy and security policies, and so we look forward to hearing from them.
Great. Well, I think that's a good place for us to take our second break. And when we come back, we're going to explore what are the building blocks of the HHIE and what are the challenges technologically to get this whole program in place. Again, I'm Josh Green, Healthcare in Hawaii.
Hi, I'm Steve Petranek, editor of Hawaii Business Magazine, and I'm going to be part of Newsmorphosis 3, a look at online news in Hawaii. And along with me there will be Patty Epler of Civil Beat and HuffPost Hawaii, Malia Zimmerman of Hawaii Reporter, Jared Kuroiwa of KHON, and moderating us all is Howard Dykes of Hawaii News Now. If you want to know how Hawaii it gets its news now and will be getting it in the future, you need to be at Newsmorphosis 3. That's at 11:30 on October 24th at the Plaza Club. See you then.
Aloha. Welcome back to Healthcare in Hawaii. I'm Josh Green, your host, and today I'm joined by Christine Sakuda. We're talking about health information exchange, health technology specifically. So Christine, we've gone over some of the big questions about privacy, who your partners are, the 20 individual organizations contributing to the guidelines so that it's safe for patients, so people don't feel that their information is out there somewhere where someone else could access it. I know these are big questions for you, but I want to get kind of into the nitty-gritty. What does it really look like, a health information exchange? We're doing this because we want savings, we want better quality of care, we want access, but where is this information? Is it in a giant, isn't it in the cloud, like we hear about so often, whether it's shared technology and shared information? Are you building data repositories? Where is this information?
Okay, thank you. Thank you for that question. The health information exchange system is a hybrid model, which means it combines two elements.
Okay.
The federated, half of the model is a federated model, which means it's very decentralized, which means that any of the stakeholders or hospitals, again, hospitals, primary care providers, labs, that connect to the health information exchange, that feed information to the health information exchange, each have their own data stage that they're in control over. So they can take their cookies and go home if they wanted to. Hopefully they won't ever do that because they see the value of the health information exchange, but that's why it's federated. So it's really inverse to everything being in one central location.
Do you mean like the doctor's office, if I have a electronic health record system in my office and I have my 3,000 patients' medical records, if I decided, I could turn the off switch and no longer that information would go into the center. Is that what that means?
Yes, that is what that means, barring HIPAA laws of having to retain information.
Yes.
But for the data contributors,
Yes.
the healthcare providers that are contributing data through the health information exchange, they do have some control over their own data stage, we call it. And that's very, very critical for the stakeholders and for the trust to be built within the system.
You mean like the labs, like clinical labs, for
Yes.
instance. They draw blood from a patient that I see, and it could be some very sensitive information.
Yes.
Maybe we're worried about hepatitis and HIV/AIDS. And I've seen a patient and they've got this challenge and I've ordered this test. Now I'm providing care, maybe I'm their primary care provider, maybe I'm seeing them in the ER, but Clinical Labs has this data. Now it obviously goes to the doctor or nurse that
Absolutely.
ordered it, right?
Yes.
But that patient wants that to be very private. How do they manage that?
Well, definitely the HHIE does have to adhere to its set of data governing principles, and that is created by this consortium of labs were active in developing the privacy policies, as well as physicians and as well as hospitals and the health plans all make sure that we adhere to the laws that exist today.
So we're already at least going to be as safe as the information sharing is
Absolutely.
in the current. Okay.
At least as safe,
Okay.
if not more safe. Because even though one could think that a technology system will have information flowing a lot more fluidly and seamlessly, it's against the law to share information that you're not authorized to share. And it is a process to make sure all the stakeholders are educated, they all understand the rules for sharing health information exchange.
Right.
So while clinical labs might have their little data stage that we ping against, they still ultimately decide on what data goes in there. It is why the community of stakeholders agree on the data that is shared within the system,
Okay.
and that agreement needs to support privacy and security laws.
Okay, so then let's assume that the agreement's in place, they're being very safe. Who has the final say as to whether or not information goes from point A to point B? Is it the patient? Is it the doctor that's seeing them that day? How does that work?
I think ultimately it's the patient. I mean, the providers are stewards of that information.
Okay.
The patients, again, do have the opportunity to opt out of the system,
Right.
which is an all opt out versus opting out of one.
Right.
But we really depend on the physicians and trust that they're using the system appropriately and efficiently, because we really are in the business of enabling the provider to give better care to the patient. We're not trying to create new ways of delivering care, but we're really trying to support the provider in delivering care better.
So we're taking an obstacle off the table. That's what this system is really then about. It's about making it easier to provide the essential care that anyone would need without the delays, without the duplications, without the mistakes, frankly, that can occur. For instance, one of the first things I think that I've seen with the systems are you're immediately asked, does this patient have any allergies to any medication? And you can't even move past that stage of your electronic health system to do other orders and whatnot until you've verified they do or don't have any drug allergies. And so you move through these safety valves, basically. And I would, I guess, also imagine that if you're going to get this information, you have to sign in and log in in a very secure fashion, so that not only can nobody get on and get access to that data, but if somebody does an inappropriate request or accesses information inappropriately, it would be very easily traceable back to that facility.
Right. It built within the health information exchange system are a set of rules. Some of them are audit rules, so actually I'll back up a little bit. Any provider that has access to use the health information system is provisioned and has to adhere to a certain set of user provisioning rules.
Okay.
So a physician does not have the same access as someone that's scheduling a patient, or a nurse practitioner perhaps, or a physician's assistant. And those rules are actually determined by, again, the governing body of the health information exchange. And it's really there to enable a healthcare provider to deliver the care that they deliver today with a common set of understanding of what they have access and do not have access to. Because we do have laws that we need to abide by.
Right.
And everyone is very sensitive about having clinical information flow across the system. So we take a very conservative approach in doing that. And so I know I'm very proud of the stakeholders for coming together and through spending hours and hours of time poring over the laws and the rules to make sure that we have good rules in place to make sure that there's no inadvertent access to health information.
Have you had any problems yet? Have there been any glitches or examples where information got out there that we didn't want to get out?
No, we haven't had any problems yet. Definitely no problems with the direct secured messaging system, our secured email system. We have not gone live with our query exchange yet. And so in fact, the reason why we haven't gone live is because we want to make sure that the rules are in place and the audit logs are in place, so that if there is a strange occurrence that exists, that the auditors can actually go in and look at that and make sure that everyone is abiding by the rules.
You mean like a request comes in for someone's lab data that just doesn't seem right?
Yes. And so you have the added protection on the lab side of their what they put into their data stage at the Health Information Exchange, and then you have the Health Information Exchange governing body making sure that the queries are performing in accordance to the agreements. Okay,
so we see that you're building very conservatively and you're putting the safeguards in. What's the next big piece that you envision coming on? I mean, when does the query section go live? When are we going to see that? Is that the big change that we're going to see?
That is the big change, and we're very mindful of when we say we're going live, because we want to make sure that the system is performing correctly.
Right.
So there's going to be a period of time where we're testing the system to make sure that everything is running accordingly. And so we're actually targeted to go live by early next year in 2014.
So unlike the Health Insurance Exchange, which had a timetable that was built into the Affordable Care Act, where the insurance exchanges had to be up and ready 2 weeks ago,
right,
where people could see the cost of their insurance and decide whether to buy it, and there's a mandate. We don't have those pressures, is that correct?
We don't have the pressure. We did not have the pressure of October 1st go live across the country like the insurance exchange. But if we had our preference of going live, we would have liked to have gone live last year, because some people say, gosh, what's taking the HHIE so long? How come you haven't gone live yet? But underneath going live, there's a lot going into that. It's not just building those technical connections. It's making sure what data is being passed. Is that data, secure? Is it safe? Are the users that are accessing the system, authorized users of the system in accordance to privacy and security laws? So all those things need to be in place.
Right.
So we're very excited that we're actually going live in the next 12 months, because we've spent the last 2 years really taking the time to build the system and the infrastructure that supports the system correctly. And the other thing that we're really excited about is, it's interesting that Hawaii is made up of small, independent, mom and pop physicians. It's not like other states where physicians are organized around an association like the Hawaii.
100, 200 docs, right?
Right. So they're really small, independent physicians, and each independent physician oftentimes has their own electronic health record system implemented in their office.
Right.
So if you have, you combine a marketplace of small, independent physicians with separate electronic health records, and there's about 30 different electronic health records in the state of Hawaii, it's no wonder that transitions of care become difficult when you cannot, when the information does not move between one provider and another provider.
So just so I understand that, because I get the gist that there's a lot on the line, whereas with the insurance exchange, if there's a bump in the road, maybe someone gets their insurance card later or there's a delay. Whereas if there's a bump in the road with the information exchange, someone's personal private information could get out, and we can't afford to have that.
Absolutely not. I mean, we really try to make sure that we have all of the privacy and security and trust agreements in place to ensure that the patient's healthcare information is protected. And it's why, again, we're starting off very conservatively with information that flows to the system. It's the most common set of data that providers need today,
Right.
to deliver quality of care. And when you have 30 different electronic healthcare record systems that don't connect to each other, and for all of the technology people that are watching the show, nationally there are no standards for electronic health records, or historically, and the federal government is trying to create those standards in the healthcare industry, like in banking or any other industry.
This is the NCQA
Yeah.
issue? Okay, so that brings us to an important question for our providers out there. Let me ask you this. We'll do some rapid fire questions. What if I don't have an electronic health record? Can I participate?
Yes, you can.
And what do I do? Then I might only be able to do the secure message piece of it?
Up until the time you get an electronic health record system.
So once I get an EHR or an electronic health record system, then I can come on more as a full participant. Is that right?
Yes. I mean, it depends if you're, let's see, we haven't quite figured out the strategy of how to connect the hundreds to thousands of independent physicians separately to the health information exchange with their electronic health record system. It's very costly for the electronic health record systems that are hosted. They're on a kind of a web hosted service or a managed service organization. It's a lot easier.
Yes.
But it's becoming more and more difficult for the standalone electronic healthcare record system to really survive at a time when the national government is imposing standards for a positive reason on technology, so that your electronic healthcare record system in your office can ultimately connect with other systems through a health information exchange. So there's a lot of healthcare transformation and technical transformation that still needs to occur within the marketplace.
So for now, these people who are freestanding might be more challenging to connect, but in the future, as the systems change, become more cloud-based, is that right?
More cloud-based, as the standards become, the national standards for electronic health record systems, electronic health record systems need to be certified.
Right.
So as those certifications become more standard, then you're able to share information a lot better with each other. So up until then, there is direct secured messaging and other technologies that we're exploring to build those connections, because physicians still need to deliver care.
Right.
And we really want to help them deliver care to their patients that see them, that see you.
Right. Okay. I think that's a good place to stop for our third break, or our final break, and then we'll come back for 5 more minutes to discuss the health information exchange. I'm Josh Green, your host at Healthcare in Hawaii, here with ThinkTech.
Aloha, I'm Maria Kashem of ThinkTech Hawaii, and I want to tell you about our ThinkTech on OC16 show. This week on ThinkTech on OC16, we'll take a look at the Honolulu Century Ride organized by the Hawaii Bicycling League on Sunday, September 29th. This was the 32nd Century Ride, and thousands of riders showed up. It was a beautiful day and a beautiful experience for the people involved. There's always a lot to come on ThinkTech. Tune in to ThinkTech on OC16. See our broadcast schedule on thinktechhawaii.com. I'm Maria Kashem, and I'll see you there. Mahalo.
Aloha, I'm Josh Green, your host at Healthcare in Hawaii, here today with Christine Sakuda. We're talking about the Health Information Exchange and how that's going to change healthcare for the positive and for the better here in the state of Hawaii. So Christine, we've talked about some of the technical aspects of sharing information, how it's going to be safe, how people can kind of rest at ease that it's going to actually make their care better, it'll be more accessible for them, that their doctors will be able to do the right things for them without making mistakes. But tell us what your vision of the healthcare system is as far as the HHIE is concerned. When we look towards the future, 5 years, 10 years out, in a perfect world with this model, what would happen? Go from the beginning when a patient sees a doctor and how their information flows and how they get their care.
Sure. In the perfect world, in 5 to 10 years, when a patient shows up in a physician's office, the physician will have all the information that they need to help treat that patient. They will understand that patient, and they will be able to provide better care on that patient. They will be able to avoid any duplicate tests that were ordered already. They will be able to understand if the patient's on multiple medications to avoid any complications related to medication. And they'll be able to really spending time delivering care to the patient versus hunting down information and looking elsewhere to find that information.
So we'll be cutting down on delays. We'll be cutting down on mistakes.
Right.
We'll be cutting down on, at least in the state of Hawaii, the complexity of traveling between the neighbor islands and Oahu to see that specialist that they want.
That's right.
What else will it mean to a patient? Will it mean that their care is less expensive?
I think over time it will mean that their care, it's hard to forecast. I think what they say in the financial forecast in healthcare is that hopefully healthcare costs will increase at a slower rate. But I do think that as the system becomes more efficient, as technology in the healthcare sector becomes more standardized, that really affords a more efficient, lower cost system. How those savings translates to all of us as patients remains to be seen. Hopefully that will result in a sustainable healthcare system, because right now we're growing at a rate that's unsustainable, which is proliferated in the media today. So I'm really excited that health information exchange is just part of a vision that really allows patients to get the best care they can, no matter what island that they're on, no matter what provider that they see, in a safe and secure manner.
I think that's a perfect way to close today.
Great.
I hope our viewers really understand how central this is to the era of healthcare transformation.
Great.
Thank you again for joining us. I'm Josh Green, your host on Healthcare in Hawaii. Today we were joined by Christine Sakuda, who's the Executive Director at the Health Information Exchange of Hawaii. Hawaii's health core, our hub for health information sharing. We'll hear more from her as the months pass and as we implement the system. But thanks again for joining us. Take care.